Good morning. Welcome to day 2 of the Age Positive 2020 Revision Virtual Conference. My name is Denise Sullivan. I'm with the University of Missouri Extension based in Jackson County and a member of this year's Age Positive Planning Committee. It's my pleasure to introduce this session and the presenter who will be presenting to us on addressing loneliness and social isolation through a circle of friends. Yesterday, we heard from 2 presenters about the prevalence and negative outcomes associated with social isolation and loneliness, and we're introduced to a few innovative programs and resources that we might add to our own programmatic strategies. This morning's workshop will further our understanding of social isolation and facilitating connections for and between older adults. Before I introduce our presenter, I would like to just go over a few housekeeping items. All participants will be muted and cameras turned off during the presentation. And if you're new to Zoom, we do want to introduce you to the chat feature at the bottom of your Zoom menu, because this is where you will have the opportunity to participate with a few of our questions that our presenter will be including. There will also be questions, time for questions and answers following the presentation. So put your questions into the chat and I will be monitoring those questions and relaying them to our presenter. And it's important that you remember our Mark's Zoom is HIPAA protected, so you won't be able to copy and paste anything into, from the chat, but all of the chat conversation, the recording of today's conference, and the PowerPoints will be on Mark's website following the conference within about 2 weeks. So it's my pleasure to introduce to you Dr. Marla Wager, professor of St. Louis University School of Social Work and executive director of the St. Louis University School of Medicine Gateway Geriatric Education Center, who will provide an overview of the program Circle of Friends. Before Marla begins her presentation, she wanted to let you know that at a later date, she will be offering a more comprehensive Train the Trainer session. And should you or your organization be interested with this, you'll have an opportunity to include your interest on the survey that you'll receive immediately following this session. So Marla, thank you so much for being with us here today.
Thank you, Denise. Very, very excited. Let me get my slides pulled up. I think I am in the shared screen. All right, there we go. Hope everyone can see. I noticed there were some post to the chat box that people were not hearing you speak, Denise. So hopefully that's been resolved. Please let me know if it has not been. So again, my name is Marla Bergwager. I am very, very pleased to be a part of this conference. I want to thank the planning committee and Mark for revisioning your earlier planned in-person conference to a virtual and to address this very important issue of loneliness and social isolation. I want to also thank and just really comment on the 2 speakers yesterday. I thought they gave great presentations, provided some good backgrounds about these issues, and I hope only to be able to build on that today. I think what both of the speakers did yesterday was, they really helped confirm a lot of things that I suspect most of the people who work with older adults in this event today already know, but they really challenged us, I think, to think more about, issues from the policy perspective, the interventions and the need for more research and the need for more evidence-based programs, and then certainly the racial and economic disparities and ageism that exist in our society. So with that, I want to just share with you a little bit about how I came to be involved in this work. As Denise said, I am the executive director of the Gateway Geriatric Education Center at the School of Medicine at St. Louis University. And we have been funded by Health Resources and Services Administration for over 25 years, first as a geriatric education center and now as a geriatric workforce enhancement program. And here's the information about that. And I want to give a special thank you to the founders of the intervention that I'm going to be talking about, Kaisu Pitkala and her colleagues in Helsinki, Finland. I'll talk more about them later. So what I'd like to try to accomplish over the next few minutes is to kind of maybe add and build a little bit on what you heard yesterday in terms of the impact, particularly the impact during COVID. There's interestingly some really great research that's really rolling out on almost a daily basis, it seems. And we're learning a lot. This was an issue before, but we're learning a lot. I want to talk about how do we assess this very, very under-assessed issue, and then to talk about a few interventions, but then spend most of my time talking about the circle of friends. So Dr. Sachin, who's the CEO of the SCAN Group, I happened to hear him on a webinar earlier in the summer, and he talked about loneliness and social isolation as an epidemic in plain sight. And I just was so taken by those words, because I think that, you know, it's true. There are people who've been concerned about this issue for decades, but it's kind of been out there in plain sight and not really being addressed. So you heard the speakers yesterday both talk about the difference. And I just, for anyone who wasn't on the call or on the Zoom yesterday, I just want to do a really quick highlight recap of what was discussed yesterday, only because it has so much relevance when we talk about assessing people who might be experiencing loneliness and social isolation, as well as how you might intervene. So as you heard yesterday, for those that were on, loneliness is this very subjective kind of difference between how we expect relationships to be and how then we perceive them to actually be. So it's that lack of connection and meeting of expectations about the gratification we get from our human relationships, where social isolation, on the other hand, as you heard, is much more of an objective measure. So you can be lonely when you're with people, but not necessarily lonely if you're by yourself. It's a very individualized kind of issue. So I think that's important, because it does have impact on how we determine if someone's experiencing either of these things, as well as how we might be able to help and support them. So I mentioned that this is an issue that's been around for decades, and it's the academic literature started showing evidence that people were concerned about this in the 1960s. And it really didn't get a lot of traction, to be honest, for many, many years. But more recently, a former US Surgeon General, Vivek Murthy, in 2017, so 3 years ago, referred to loneliness and social isolation as a global health epidemic. And in the upper right-hand corner of my screen, it's a screenshot of the cover of the book that Dr. Murthy has just published. It is hot off the press, and I've just ordered it, haven't even had a chance to read it yet. So I encourage you, if this is a topic that you're interested in, please do look the book up. As you heard yesterday, then National Academies of Science, Engineering, and Medicine report, which I think is just very groundbreaking, you heard reference to that yesterday, refers to it as a major public health concern. Cigna back in 2018 did a study of 20,000 adults across the US, all across the entire age spectrum. And I'm not going to read through these, you can scan these, but I think that the numbers are startling. And I think they really challenge us as providers in healthcare and social service settings and society in general to begin to address these issues. I think that it's also particularly poignant that loneliness and social isolation are not things just related to the older adult population, but our entire society is experiencing them. And then there's this one piece that we don't hear a lot about, and that is that oftentimes people are lonely or socially isolated because they feel like they're not being understood by others. I'm going to come back to that point here shortly. You heard also yesterday about predictors of loneliness, and there are many, but I only show this not to be redundant from what you heard yesterday, but to show that some really recent research has shown that depression, living alone, feeling poorly understood by others, which I said was an issue I'd come back to. And then for the LGBTQ plus older adult population, these are particular risk factors that seem to be, statistically speaking, stronger than maybe some of the other issues that we've heard about. So you also heard yesterday that the impact of loneliness is the equivalent of smoking 15 cigarettes a day. But it's also, in the same study, was found to be a greater health danger than one of these four items here: cancer, cardiac disease, obesity, and substance abuse. Which do you think it is? And enter, if you will, your response in the chat box. And I'll just wait here a couple of minutes because I'm going to give you the answer on the next slide. So I don't want to progress to the next slide. So Denise, if you can kind of watch that and sort of give me your general sense of which of these four items our participants and audience are selecting.
Wow, there's a kind of a good spread, but I'm seeing, seems like mostly obesity and cardiac. No, there's a lot of all of the aboves coming in.
Okay. All right. Well, let me share here the response. So loneliness, as you heard, impacts us across many, many different areas of our lives. And again, there's research that's just hot off the press that is just coming out, and I'll point to one of those here in a minute. But if you look over on the far left-hand side of your screen, the bottom one, loneliness is more dangerous than obesity and as damaging as smoking. So those of you that chose obesity, you were right on the mark on that. However, I think that, as you can see and heard yesterday, it can be significant in terms of hypertension, mood disorders, weight gain, which clearly links to obesity, smoking, substance abuse, alone time, frailty. But one of the studies I do want to point out is there's a study that just came out, oh gosh, within the last month I saw it, that there is a definite, and this has been known before, but this is a more significantly high number, 40% increased risk for dementia. And that's the Sutton study that came out. And I think we really have to pay attention in that issue. We also know that people who experience chronic, particularly chronic loneliness and social isolation, end up having more emergency room visits. They do tend to go to their primary care physicians more frequently, and oftentimes will be institutionalized in a residential care facility earlier. So let's shift a little bit here and talk about the issues of assessment. And I want to talk about assessment because this is an issue, these are issues, both issues are dramatically and radically under-assessed by all of us. And I think that we have to be asking the questions, all of us do. This quote here I thought was great, and all the boxes are in the way here, so let me see if I can move and read that. So loneliness automatically triggers a set of related behavioral and biological processes that contribute to the association between loneliness and premature death in people of all ages. And Casipia Oppo, I think how you say her name, she is one of the major researchers in this area, and I think these are important words for us to think about, particularly in light of the information that I just shared with you. So we know that the typical physician, nurse practitioner, healthcare provider is not asking. And every time I give a talk on this issue, I ask the group, and I won't ask today, but I typically ask for kind of show of hands of how many people have ever had your primary care or any physician or healthcare provider ask you about the issues of loneliness and social isolation. I have yet, in doing that over the last couple of years, I have yet to actually have anyone say that they have been asked that. So I think for that reason, I think that it's even more important that we raise awareness. And you heard, I think it was Emily who talked yesterday about the need, particularly within the healthcare system, to raise the issues of the need to ask the questions. And I'll give you some suggestions on questions. So there's two different ways to ask these questions. And you can certainly have standardized tools, scales, and there's some, and I'll make some suggestions about those. And it seems like, the people who study these issues kind of are mixed. Some use 3 to 6 item measures, the shorter the better, of course. Others just have single questions. Please take note of this little footnote at the bottom. Someone actually studied the fact that women are more likely to respond to a question if they're asked directly, are you lonely or socially isolated? Where males are maybe not quite as forthcoming in terms of how they are experiencing either of these issues. But if you ask them to complete a scale or a questionnaire, then you're more likely to get at the information. So I think that's just something important for us to remember. The other issues that I think are unfortunate and speak back to an issue that was raised yesterday around ageism. All age groups tend to overestimate the number and percentage of older adults who are lonely. Older adults don't necessarily, but across the age spectrum. So again, there's this kind of stereotype that we have about, we as we age, we kind of end up being alone. And it's not necessarily the case. The numbers are high and very worrisome, obviously, in terms of those that are experiencing it. But I don't think that, it's as an assumption, an ageist assumption, that we should make that all certainly are. So in thinking about how to measure and to get at whether or not someone is experiencing loneliness or social isolation, as I said, you can use the standardized measures. You could certainly, assess mood, which I hope healthcare providers are, but we know, they have limited time, so we know that may not be something that's routinely asked either. You can come at it from the perspectives of depression and anxiety. Now we know that both of those things tend to be linked to loneliness and social isolation. You can be either of the things without being depressed or anxious, and you can be depressed and anxious without being lonely or socially isolated. But there are linkages. We know from the research that's been done, we know there are correlations. Certainly to ask about social support, and there's a really good scale that I'll talk about in a minute, a short one that gets at that. And again, loneliness, there's a couple of really outstanding loneliness measures that get right to the heart of the issue. And then certainly, if we do a good job raising awareness among healthcare providers around the issues of physical health, there are going to be some red flags potentially that come up in any kind of an intake or ongoing, kind of health or social service related relationship. So, listen for those red flags or be aware of them and encourage people to talk to their physicians. One of the things that I think we all need to also recognize about both of these issues is there's stigma attached. And anytime there's stigma attached to anything, any issue, people are far less likely to be candid and to be open. So I think in some ways we have to know our patients and our clients. And so we have to know what is the best way to be able to learn more about what this person's experiencing. So the other side of this, if you don't have the way or ability or time to do standardized measures, there's open-ended, qualitative kinds of questions. As I said, women respond well if you say, are you feeling lonely? So asking someone their self-perception, and then certainly to ask a very objective kind of concrete question about how, within a specified period of time, in the last week, in the last, in a typical month, how often do you see family, friends, and what kinds of connections are you having? Are those in person, pre-COVID, and maybe some now, phone, online, those kinds of things. So there's lots of ways to assess this. If you have the luxury of being able to do a comprehensive assessment, which is always ideal and often not, then, what I certainly would recommend would be, this would sort of be the gold standard of all things that you would want to assess. And there's a lot of reason to assess these things for other reasons besides loneliness and social isolation. But here's the red carpet sort of approach to this. So certainly cognition. We know there's a link between cognition. So we know it's a multiple faceted link, because we know that people who are lonely and socially isolated can become cognitively impaired due to the lack of cognitive stimulation. But we also know people who are already experiencing cognitive impairment also can be lonely and socially isolated, because they may perceive that they are not interacting, people don't understand them, they're not following conversations. So you really do want to get a handle on cognition. And then I've included here references to some of these if you want to explore these further. So as I mentioned, depression, anxiety, the CDC makes available the Depression and Anxiety PHQ-2, which is a screening tool, which you then can go on if it indicates that there's potential depression there, you can move to the PHQ-9. And these are both excellent resources and copyright free and all of that. Generalized Anxiety Scale is a short scale that will help you understand the level of anxiety, which again has been connected. I mentioned social support. A social work colleague at Boston College, Jim Lovin, and a team created the Lovin Social Network Scale some years ago, and they've got a short 6-item version of it that works extremely well. Also, it's very conversational. Asks about, who might you go to, if you were concerned about something? How often do you see family and friends? So it's not an intense kind of administration. And then loneliness. The one that's been around for the longest time is the UCLA Loneliness Scale. There is also a short version of that. And then we developed, just this past year, a scale called the Alone Scale, using the mnemonic alone, of course, and it's copyright free. It is not yet validated. All these other measures that I've shared with you are validated. The Alone Scale is not, because it's brand new, but we're in the process. And then also you want to look at mobility. And we've developed a scale at St. Louis U called the SARC-F, looking for sarcopenia specifically and frailty. And because again, there's a link. If one isn't being active and isn't connecting and going out and seeing people when we can, then you run the risk of becoming frail and experiencing muscle weakness and loss. But the flip side is also true, just as it is with cognition. So just asking the questions is really the most important thing. Some sample assessment questions to kind of come at this more conversationally. Tell me about your daily life and routines, or your life overall. And if you feel that the client or the patient will be forthcoming, ask what you think about loneliness. Are you lonely? Tell me about your interests. I think if people can talk about the things that they're passionate about or are willing to spend their time with, then you'll get a sense of, is this a solo activity, or is this something that they have to do with others? So I would really appreciate if you have other thoughts about questions, or if you have questions that you ask as part of your own work, please put those in the chat box as well. I'll keep moving, and Denise, maybe at the end we can kind of go back and see, because I I think we can't ever have too many ways to get at this. So any additional thoughts that you all have would be greatly appreciated. So I wanted to share with you, here's the Alone scale, and it's available. It's right free as all of the measures that we develop at St. Louis UR. Alone, are you emotionally attracted to others as a friend? Are you lonely? Are you outgoing and friendly? Do you feel you have no friends? And are you emotionally upset or sad? And as I said, because it's not yet a psychometrically validated scale, it's really right now, hopefully helpful as a clinical tool. So you just get, if there's 3 of these in which the person suggests that they're lonely, I think that will be an indicator for you that you need to pursue the conversation further. All right, so with the time left, I want to spend the bulk of it talking about interventions. And you heard about some yesterday, so I won't necessarily talk about those, although make a couple references to them. But I think as kind of a lead-in to thinking about how to intervene with this, I think the wisest thing I heard someone say was, one size does not fit all. And that is so true, because the way people experience loneliness and social isolation is so unique to the individual. The way I present may not be the way, the next person presents in either of these things. And remember, we also have to think about the stigma that is attached to this. So people often not being particularly forthcoming. The box up here was a quote. Sandra Edmonds-Crew was a presenter on a webinar I attended, and she said, social isolation is a micro level consequence of a macro level social forces. And I think you heard some about that yesterday. We have kind of these 2 issues happening in our society. Dr. Sachin, who I referenced earlier, who said it was the loneliness and social isolation were an epidemic in plain sight. He also, I saw him, I think, in the same webinar that I saw Crew. He talked about the fact that at the beginning of the last century, we were the most, or one of the most, age-integrated countries in the world. And today, we are actually at the bottom of the list. So as you heard, I think it was Kathy talk about yesterday when she shared the experience of Dr. Thomas in the nursing home, how nursing homes have really begun, while the intent obviously was a safe and healthy place for older adults to live, they can be segregating. And I applaud those facilities that really have made an effort to bring in, other age groups. I just heard about a facility, it's probably not the only one in the country, that actually has a childcare center in the nursing home, so people can interact with children throughout the day. One of our adult day programs here is next door to the childcare center at the agency. So I think, we need to be looking at our society. Have we really segregated older adults? And what can we do about that? So in thinking about interventions, they've been around for a while. They are not new, not necessarily always were they evidence-based, but the group in Finland that I mentioned earlier who developed the intervention I'll talk most about, Circle of Friends, they began to look at this 20 years ago, I think now. And what they found was that some of the interventions were promising, but the dropout rate was very high for Circle of, or for initial kind of beginning interventions. So, they studied this, they talked to people, they talked to older adults, and they concluded that an effective intervention to address loneliness and social isolation would include physical activities, cognitive stimulation, and facilitators who understood group dynamics, the concept of empowerment, and that the issues had to be person, client-centered, and they needed to obviously promote interactions. So my colleague and friend, Philip Rosario, social work faculty in New York, he wrote a piece recently on some of the trends in older adults, and I read this and I really liked this statement. He said, the idea of people wanting to age in place sometimes ends up with them aging in isolation. So we need to look for ways that we can help people age in a more connected way. And that unfortunately means that we as a society have to commit to that. So I think that's very much what you heard yesterday, and hopefully what you're going to hear throughout the rest. So let's look at kind of how we might approach this. So we need to engage, we need to look at the impact, and we need to look at how can we sustain things. So we've got to be creative, and I think you heard about the need for creativity yesterday. We need to, look at population-based approaches kind of across the spectrum. We need to be very proactive, far more so than we have been before. We need to, build on the local knowledge networks and community organizations, all of you that are already engaged in some of these activities. I remember yesterday when the speakers asked us how many of you have been involved in this before COVID. It was good to see that a number were. And we need to use multiple ways. To use a way overused cliche, it really does take a village. And I think we all have to think about what is our part in all of this. And is it raising awareness? Is it getting people to assess? Is it developing programs? Is it changing policies? So I think figure out for yourself and for your organization, where do you fit in all of this? So as the bubble up here at the top says, this is bigger than the physician. Yes, we want the healthcare system to address the issue, but they're probably not in many cases going to be in a position to do anything except do social prescribing, get people referred to appropriate resources. But there are some things that they can do. And it's, I think, all of our responsibility to kind of encourage awareness, to ask the questions, and then to know what the red flags are. So treating the health issues that can limit people in terms of their interactions and mobility. The list here is not all encompassing, obviously, chronic pain, the sensory impairments. You heard a lot yesterday about sensory impairments, even things like incontinence and foot health and oral health. All of those things, certainly to address the mood issues, the cognition issues. We know geriatric assessment works, but we also know that the number of board certified geriatricians is plummeting. It's back now at the level that it was in the 1970s. It is just not a specialty that is being sought after by medical students and residents at this point, unfortunately. So we have to rely on other kind of things, but we do know a comprehensive geriatric assessment will pick up a lot of things that will help people stay home longer. We need to make sure we're open and clear in our communication. One of the areas that we haven't talked about yet is the caregiver. Making the caregiver part of the healthcare team, particularly if the person has any kind of cognitive impairment. But we also, and we know particularly right now during COVID, that caregivers are an especially vulnerable group in terms of being lonely and socially isolated. So I think we need to be very mindful of those things. So what can all of us who don't work in healthcare, what can we do? We need to keep asking the questions. We need to be encouraging our communities to address these socially isolating practices that occur, look at policy changes. We need to address the issues of stigma and ageism, and we need best practices. Hopefully I'll share one with you here in a minute. And we need some one-on-one kind of interventions, as well as the group. And this is where the assessment piece comes in. There's a school of thought that says group interventions work well to address social isolation, where one-on-one interventions work for loneliness. We're actually looking at that very issue now. So stay tuned. I hope to have more information. So if you're going to do a group intervention, which is what most of them are at this point, it's important to know the people beforehand. We're getting ready to start a Circle of Friends group next Monday, in fact. And we've interviewed all the participants. We've tried to find out what their expectations are, what are they looking for. And we're doing these groups virtually. I'll come back and talk about that. And we need to be very clear that, this intervention, whatever that programmatic issue looks like, is to help you get connected to other people. And I think that we certainly hope that people can become part of a group, if that's what the intervention is, and then the facilitator can fade out because they've done their job. So I wanted to just talk real quickly about 3 different kind of intervention examples that we heard a little bit about one of them yesterday, and I won't spend much time on any of these, just to make you aware that there are some out there. So friendship benches, I love this approach, and the only place that I've seen any publications or research actually comes out of Africa. And it's a bench, literally a bench that's put out in front of a primary care clinic, and they train grandmother health providers, older women, to sit on the bench and chat with people for 30, 45 minutes. And you can see here, they found that depression scores went down. People felt that healthcare was more accessible and flexible and patient focused. They felt like they got support. They felt like they got immediate service. And it was a low-cost intervention. This is an easy intervention that we could do. So kind of moving on, in the UK, they have taken this issue of loneliness very, very seriously. And the Prime Minister appointed a Minister of Loneliness in 16, 17, I think it was. And they've done a number of different kind of countrywide initiatives. One of which is they have the chat benches. And in recognition of the UN World Elder Abuse Awareness Day last year, the UK police departments launched their chat bench program, just where people can sit and visit with anyone. Befriending services, especially those using technology, you heard some about that yesterday. These have been around for a very long time. My very first entree into social work was as a BSW at K-State in my intro to social work class, and I was adopted, kind of a mutual adoption with an older adult who lived in a high-rise and was really homebound. And I visited with her, and we developed a relationship over the semester, which continued on after my class ended. So those programs work. And right now we're seeing an explosion of kind of the phone reassurance and some online kind of check-ins that are happening now. And I'm hopeful that those will not go away after the pandemic, because the problem is not going to go away. Lots and lots of stuff out on the market that you heard about. But you know, the thing to remember about technology, and I think the point was made well yesterday, that it's not in place of, and it's not always ideal, and it's not accessible to everyone. So we have to be mindful of those issues. I've heard one speaker say, remember, the phone is a great communication tool. So co-living arrangements, I heard someone refer to it as the Golden Girls phenomena, are beginning to spring up now, and these are not for everyone, certainly, but they do meet some really important needs for some people who choose not to live alone for health or financial reasons or social reasons. So that sometimes they're matching intergenerationally, and then sometimes older adults are coming together to live. So co-housing. 2 of my colleagues have written a book. They traveled around the country and looked at 14 different co-housing models. US. And these are everything from people come together in a community, they have a governance structure, or it's something maybe more loosely organized where people actually, you know, live in the same house that they rent or own together. So they've taken on many different forms, but it's important, I think, that we all know about these options and know if there's anything in our various communities about it. One of the downsides that my colleagues pointed out is some of these are very costly to buy into. So I think that we have to again, be thoughtful about, you know, what are the needs of the individual. All right, so Circle of Friends. It is an evidence-based intervention that was developed, as I said, almost 20 years ago at the University of Helsinki in Finland. They have been very prolific in their research and their publications on this, so there's a lot out there that's evidence that it does in fact work. My colleague, John Morley, who I co-direct our geriatric program with, met the group in Finland when he was there giving a talk and came back and said, we need to do this. So we've been training now for over a year on this. And as far as we know, we're the only people in the US that are doing training and running groups now in the St. Louis area. Would love to see it expand to the Kansas City area as well. It's a group intervention. The sole purpose is to alleviate and prevent loneliness. The group meets 8 times over, meets 12 times over a period of 3 months. The ideal group size is about 8, which is true for any sort of adult focused group. And it's very much based on what the group members want to do. So as opposed to the facilitator always coming in and saying, okay, here's what we're going to do today, or here's the topic we're going to discuss today. The topics, the issues are generated from the group members themselves, which I think makes this program somewhat unique in that sense. The other unique feature of the Circle of Friends group is that it's absolutely intended at the end of the 3 months that the group continues on without the facilitator. So you know you've been successful when the group has bonded, they become connected to one another, they become a support system for one another, and you as a facilitator are no longer needed. So we got carte blanche permission from the founders, who we've been in touch with many times over the last couple of years, to adapt this in the US to the various populations that we all serve. And we have been offering this at our SLU Memory Clinic for a number of months, and I'll talk about how that had to transition to virtual. But then we have 2 community partners. One organization works exclusively with older adults with developmental and intellectual disabilities, and the other is in a public housing program. And they have been offering Circle of Friends and are also getting ready to pivot to a virtual delivery. So the evidence is overwhelmingly strong. The founders have trained over 750 facilitators, and they've engaged over 10,000 years that they've been doing this. And just the important points to show from these statistics is, they've done follow-up studies, and they found that after a period of time, they have a very low dropout rate. About 40% of their groups continued to meet after the facilitator transitioned out. Cognition improved. 95% of the study in 08 and 9 reported that they were no longer lonely. Big range of people who said they met new friends. And again, they felt like there were meaningful activities, and they felt like they were needed and a part of something. So the same group in Finland did a 10-year follow-up, and they to those studies that I just talked about. And the numbers actually of the groups that continued to meet was higher. It was 67% in the 10-year follow-up. 87% said they were no longer feeling lonely, which is slightly down from that 95%. And then 70% compared to 45 previously said that they had made new friends. So from a research standpoint and a clinical intervention standpoint, the Circle of Friends is really thought to be an effective long-term option for people to address both of these issues. And we also have to think about, though, adapting it. We're not Finland in this country, and our various populations are not Finnish. And so we have to make it very much individualized to the populations that we serve. Why does it work? It's, as I said, based on positive group-based input. So the group members determine the topics, the structure and format of the group in a minute. There's ongoing evaluation, constantly asking, people, is this what you're expecting? What did you want? And we know that when you stimulate the brain, you're creating new neural pathways. And so hopefully that's what's happening. And it also is impacting the neuroendocrine system. to improve all of those things that we learned earlier and yesterday are the negative impacts for this. So member involvement, you know, we're always much more invested in something when we have a part in creating it. And I think that that's one of the keys to the effectiveness of this intervention. The low dropout rate, and they have a very low dropout rate, has to do, I think, with the fact that facilitators are well trained, and with both of our groups, all three of our groups actually, the facilitators meet on a regular basis, either weekly, in the case of our SLU clinic, and then I was meeting this past year with our partners in the community on touching base monthly. And then also getting, so these are just, the next few slides have pictures from our Circle of Friends groups. And by the way, if you Google just Circle of Friends, there's all kinds of things that will pop up, from dating agencies to childcare. So you, if you want to read more about the original Circle of Friends in Finland, you have to put in Circle of Friends Finland. I've got the. Every session includes 3 different components. They're, and again, developed and inspired by, I guess you could say, what the individuals in the group want to experience. So one has to be sort of this creative piece. It can be bringing in artists or attending cultural events or creating something artistic. You know, now with everything gone virtual, our group on Monday is, they're going to be at some point, I don't know if they'll do it Monday, but at some point, the graduate students who are facilitating the group are going to have the group do, watch on the computer, of course, a tour of the Louvre Museum in Paris. And there's lots of museums, lots of places have those kind of 2D, 3D kinds of tours available. So we have to be creative. You're only limited by your own creativity here. And every group session has to include something health related. It could be group exercise. It can be chair yoga. It can be, if in days when we're not you know, stuck at home and doing this virtually, it could be, you know, an outing, some kind of more physical kind of thing. It could also be having a discussion, having a speaker come in and talk about nutrition. What's the Mediterranean diet we keep hearing so much about? Talk about those kinds of things. And then this last part is the reflection piece. The protocol developed in Finland talks about it in terms of it being written. People write and journal about it and then reflect on it. But it can, if writing is not something that's works with your particular group, you certainly can just have a conversation. Our groups in St. Louis have done some really interesting and creative approaches to this. So who's appropriate? Older adults who report feeling lonely, willing to participate, and for telehealth delivered interventions need to have access to a phone or laptop. Have sensory impairments certainly can be present, but they can't inhibit the person from being able to participate. And this intervention is not developed for people with cognitive impairment, but persons who are mild, you know, MCI, mild cognitive impairment, to early moderate can certainly participate. So that's the intervention in a nutshell. And as Denise indicated, we are certainly happy to come back to the Kansas City area and do a full training on it. We've done it virtually, and we're happy to do that, and would love to see some Circle of Friends groups coming up in your various areas. I know not everyone's from the Kansas City. I want to just talk in the last couple minutes here about what have we learned about COVID. As I said earlier, there's just research coming out all the time. You can see over here in the box on the side, this study just came out of Spain in the last, I don't know, week maybe, that talked about, you know, loneliness increased, stay-at-home orders, increased loneliness, not surprising. And there's a really great questionnaire that's available on this website for being able to learn about the impact of COVID on older adults. So what have we learned? We've learned relationships are important. And I think what's particularly significant is we've all learned this. Most everyone in our society has been impacted in terms of loneliness and social isolation in some way. So we know we need to stay connected. We need to plan for crises like this, which many of us have not done. We need to really pay attention to what people need and what they're feeling. And we know that we all as humans want to be involved in meaningful and stimulating activities. We know we need to attend to our physical health, which has been challenging, I think, for many people, particularly in terms of older adults going to see healthcare providers. And we've learned a lot about technology. We've learned that, you know, you don't have to be a computer wizard to use technology, but we also learned that not everyone has access or literacy. And I think most of all, I think we've learned that we need to have a news diet in terms of just overwhelming, because that certainly adds to stress and fear. As providers, you know, we've also learned that ageism and health disparities still exist and have come out in very, very unfortunate, ugly ways. We know that there's a lot of fear and anxiety among older adults, and many of us, but older adults in particular, about the post-COVID period. So we need to be prepared to address those issues. We need to be creative about reaching out to people. Writing letters maybe has become a new thing. I think particularly for those older family members and friends that are in care facilities, I think letter writing has actually reemerged. And we know that technology should be designed with older adults in mind and persons with disabilities, but we know that currently, although there's some changes happening, we know currently it tends to be adopted or designed for a younger population, and then with the expectation that older adults adapt. So, and we've learned about self-care. So I mentioned, so we transitioned our Circle of Friends group to telehealth in the spring, and we are starting 2 new groups this month. And it has been a learning. It's been a steep learning curve, and just some tips. And we go into much more in depth about virtual delivery in the full training. But we have learned that it's hard to get, it's challenging to connect if they don't have a previous connection to one another or to a group like this. It's hard to get people to engage as a first time into a virtual group. You have to learn, you know, even if you have group experience as a facilitator, we know that that group management of groups can be challenging. How do you deal with that virtually? So we need to talk about that. And then we also know that, as I've said and you heard yesterday, that, you know, these issues are tied to depression, anxiety, and other health issues. So we have to be able to gauge those in a virtual environment. And how do you engage people that don't have access to Zoom, for instance? So we experimented with phones and putting people on speakerphone. So how do we address this to wrap up here at the community level? We need to increase education and awareness, absolutely. We need to address the structural issues. We need some policies that will be supportive of this. Circle of Friends is not considered a clinical intervention unless, of course, you know, you build it as a therapy group for people with depression and anxiety. But we need support from the insurance companies and Medicare and Medicaid to be able to support interventions like this one. And we know there's evidence that we need to address it. We know there's a beginning number of evidence-based interventions, and we know that we can use technology. So we need to just capitalize on those at a much larger community level. On the individual level, we need to make sure that what we're doing is tailored to the individual and their needs, and not stigmatizing. We don't want to get that. We want to make sure that we are addressing the whole person, and we want to also make sure that we're helping people make those important connections. AARP's resource is absolutely wonderful. We've encouraged people to do that, and to also, you know, develop an action plan for how, as you heard some about yesterday. So, a slide here. Older adults, you know, are at the heart of this, obviously. So we need to start with the idea that this is very much a multifaceted approach. Again, using the overused cliche, it really is going to take a village for us to address this issue. You know, we need at the policy level to have programs available, to have funding available for this. We've been very fortunate in St. Louis to get some COVID rapid response funding from 2 different organizations to be able to support the starting of our new groups at the SLU Memory Clinic. But we need people who are open to thinking that this would be a good use of their money. They're not getting huge numbers, but what I think we're getting is a significant impact. So we need, you know, just the general population and the providers, whether it's social workers, people who work in aging services organizations, healthcare organizations. We need them to all of us need to be mindful, need to be thinking about, you know, is my neighbor socially isolated? I don't see a lot of traffic going in and out of her house. Wonder, you know, what that means. Just to be thinking about it in ways that we haven't. COVID has actually helped us in some ways with that. So we need family to be involved in this process. We found that family have been very helpful with the technology for the virtual groups, but we also just need them to be connected. And we also need to look at, you know, as I said, in the case of caregivers, is this somebody who's at risk as well? Caregiving is a tough job, as we all know, and can have some significant mental health and physical health implications for the caregivers. And you layer on top of that, feeling lonely and socially isolated, particularly now. And then older adults need to feel safe, and they need to feel like they're being heard and their issues are being addressed. So with that thought, lots and lots of resources here. The Circle of Friends group in Finland have a great website that automatically translates into English if you click the button on it. We have a COVID page, and we have we have just uploaded a presentation on Circle of Friends, actually, at our website at aging.slu.edu. You heard all about the ARP. SAGE has a great program. There's a number of social networking sites. You know, I could have had pages and pages of resources here, but I've just chosen a few to highlight. Lots, if you want to do more reading, lots of good resources out there. The National Academies report that was just, I think Emily mentioned it, and the ARP Foundation, obviously, you know, have excellent resources. Lots and lots of resources. If you really wanted a deep dive into this and to learn more about Circle of Friends, I have actually a full reference list of all the references that were included in this presentation. Just send me an email, which you're going to get my email here shortly, and lots. So I want to put in a promotion for our education center. Has an asynchronous webinar on the impact of COVID-19 on older adults. It's going to be available through the end of this year. It's free, comes with CEs, 3 of them, and there is a presentation by me on loneliness and social isolation. We also are revisioning our what was supposed to have been our 31st annual Summer Geriatric Institute. We're offering that as a free event on Friday on October 2nd and 9th, on 2 consecutive Friday mornings from 8 to noon. Again, free with CEs, and we will talk about virtual delivery. It's a range of topics, but we will address social isolation. And for more information, there's our website. And there is my information. So thank you, and please do indicate on your evaluation that will come after I finish speaking and we do Q&A. If you are interested in Circle of Friends, be more than happy to come back and in whatever form that might take, virtual or maybe one day in person, hopefully sooner than later, to talk more about this really wonderful intervention. So that is the end for my remarks and my comments. Denise, I think we're open to questions now. I don't know if there was anyone who had any thoughts about other ways that they might assess the issues of how to assess loneliness and social isolation. I'd ask folks to put that in to chat box if there were any there, or just questions or comments.
Yeah, I mean, when you were discussing, assessments, I found it real exciting that there were several people that had said that their healthcare provider had asked them in their recent visits. And
Excellent.
So that's exciting to hear. And I got to thinking, it's like, yeah, I guess they have, my doctor did do that this summer. So
that's interesting. I wonder if they did that before COVID, or whether that's been a COVID inspired kind of thing to ask people about.
Yeah, I mean, I certainly didn't recall personally, that had been asked before. Mm-hmm. So, but now you made me think about it. So, so that was it. That was really exciting. Did have, a couple direct questions. One that you answered, they'd asked about the specific types of activities for Circle of Friends. And so you answered that. And I'm excited, to think about that. It's like, I see places, for extension to be, a part of that, if we could get something like that going. And there was a lot, several comments in the chat saying, yes, we need to find out more about this. So I think we'll see that on the survey.
Well, one thing that I do want to point out, we are currently doing groups in the St. Louis area for community living older adults, people living in the community. But I think we really should think about this for residential communities, so care facilities, assisted living. I saw a study recently that said 75% of people living in skilled care were considered to be lonely by their own self-report. So I think we're not limited to just people living in their own homes in the community in terms of this intervention.
Sure. There was a question on policy, if you had examples of policies at the municipal level that have been effective.
Oh, at the municipal level. Well, let me start by saying I am not aware of any policies in the U.S. That doesn't mean there aren't out there. I have not heard of any policies that have been enacted. Where I've heard about it, which I shared, was the work that's happened, the shift that happened in the UK in terms, to have a minister of loneliness for the whole country. Yes, absolutely. We're enacting things at the national, but as well as the municipal levels. I do think, and I know many people, who are here today probably are very familiar with age-friendly health systems and dementia-friendly communities. Those are both also areas that we're very involved in through the current HRSA grant that we have. And so I think that as we start to hopefully expand, not just we collectively, society, I think as we start to shift our communities to being more dementia friendly or even just age friendly, I think that we may not see municipal laws enacted, but what we may see is municipalities adopting things like chat benches, like funding, local programs to offer kind of Circle of Friends groups or other interventions. Doesn't have to be just Circle of Friends. I think that we need this kind of bigger, wave to come through that and make sure that loneliness and social isolation don't get left out. My greatest fear is that after this pandemic is over and we've returned to whatever life's going to be after this, that we're all going to forget about this. And so I think we need to make sure that doesn't happen.
I don't see any other comments in the chat. So I do want to remind folks, you will be getting an email with the link to the evaluation survey following this session. That's where, please, if you're interested in Train the Trainer workshop, please indicate that on there. And that's where that information can be compiled. So Marla, thank you so much. It was a pleasure to kind of get to sit with you across the screen.
Yes.
And we would like to remind everyone that we do have another session that will start promptly at 10:30, programming for a moving target. At the close of this session, you'll be moved to a waiting room while we reset the Zoom, I guess, and then be admitted back into the Zoom session that will begin promptly at 10:30.
So Denise, I just saw a question pop up in the chat box about, will the training be offered other than in Kansas City? During this period, we're obviously doing everything virtually. So, if a group in the Kansas City area want to organize like this event today, it would certainly be open
Sure.
to everyone. And if you have a group, if we don't do something in Kansas City, but somebody else has a group that would like to come together, please just email me. Again, my email is marla.bergwager, no hyphen, @slu.edu. And I think that, we could, all we need is a Zoom connection and my colleague and I to do the training.
That's right.
We are happy to do that, and that's part of our grant. We cover the whole state of Missouri, but we're not limited, certainly by state lines. We're happy to present, especially an intervention that we're so passionate about.
Very good.
All right. Well, enjoy the rest of this. Again, thank you. I've been really honored to be part of this, and look forward to maybe doing this again in a more extended form.
Very good. Thank you so much.
Thank you. Bye.